I want to turn now to Ian Towne, who is Chief Scientist of the Ministry of Health in New Zealand. And as everyone here, I'm sure, knows, I think many would have preferred if what New Zealand did was what everyone else had done, and we would now be enjoying the joy and conditions that are present in New Zealand. So Ian, thank you very much for joining us and helping us understand how you've been so successful. Thank you.
Well, thank you, Yaneer. Can you hear me clearly? I'm a long way away, but
yes,
I've
yes,
got
we can.
well.
And thank you for joining us early in your morning.
That's fine. Can you see my screen share, colleagues?
Yes, we can. We can see your screen.
Thank you. Well, a very warm welcome from down under in New Zealand, and just want to start by acknowledging the courage of our colleagues around the world, including those speakers who have stood up for what they believe in and who have championed science. It's very distressing for us here in New Zealand to see friends and colleagues in science and the medical profession suffering so badly with the pandemic in other countries. And so I want to just acknowledge that, and there's no sense of smugness or overachievement in New Zealand. We remain watchful and cautious in regard to the ongoing risk that we all face internationally with this pandemic that's out of control in so many countries. So my background is as a respiratory physician. I've been here at the ministry for 2 years. I wasn't expecting to be in the eye of a storm, but in some ways my professional background assisted me to understand the risks of uncontained, of a pandemic of a viral nature such as COVID-19. So in the next 20 minutes, I'll just go through the slide deck with you, which will chart the course here in New Zealand. I'll try and comment on things that may be helpful for colleagues in other countries, and naturally happy to be contacted afterwards. So we've just come back from our summer holidays, and it's exactly a year ago that we returned from those holidays to the early reports from Wuhan. And like many of us, we had no inkling about what was to happen here in New Zealand and worldwide. So this paper in the Lancet describes the early New Zealand experience. I'll use some of the illustrations from this to tell you a little bit about the time course and the management of the pandemic here in New Zealand, but this is an excellent summary of the early days. And from that summary, you can see here the graph which shows the exponential growth in cases. For our Irish colleagues, I was once quoted as saying, "What part of exponential don't you understand when trying to explain the risk?" And of course, here is the small but exponential growth of cases in New Zealand. And of course, all our cases were imported, the first case from Iran, and the outbreak proceeded throughout March with import-related cases and then local transmission, community transmission from about the 15th of March through towards the end of April. And that was the initial pattern. And here is the extended case report numbers on a daily basis from here in New Zealand. You can see there on the left of the screen the condensed version of the March, April, May outbreak, and then a prolonged period of no community transmission. The middle of June, we detected cases in the community. And this graph looks very like the graph from New South Wales in Australia, where we've continued to have small outbreaks, cases latterly, all breaches in our managed isolation facilities where there's been a leakage of a case, usually through a staff member. And we're currently dealing with such a breach right now in the late part of January. So we have a number of cases that have breached out of one of our quarantine hotels in Auckland. There will be nothing surprising here, only the small scale of the age distribution here in New Zealand, and only 25 deaths have occurred here, and they are illustrated in those tiny red bars you can see, which are illustrating the same pattern of the majority of deaths occurring in the very elderly and those with underlying medical conditions. This is our daily situation report, which at a glance tells you roughly what's been going on in New Zealand in the recent time. So you can see there that on the top right-hand box, the new case that was identified from the hotel a few days ago. There are now 5 or 6 cases, all from the same floor in a single isolation hotel. The number of laboratory tests, the number of cases that have now recovered. And as you can see, New Zealand has been aggressively testing anyone with symptoms, with about 1.5 million tests having been completed so far. So you'll be hearing shortly from Professor Michael Baker, my colleague at the University of Otago, and he will, I'm sure, refer to the early modelling. Many countries, of course, undertook modelling using the same or similar methodology, the early discussion about what the R0 value meant, and then the predictions about the number of deaths and the number of health service challenges that would be encountered in the absence of control measures. So it was the early modelling, and we had local modellers, including Professor Nick Wilson, Michael's colleague, and those models certainly alarmed the politicians in New Zealand, and I've used the word galvanised before. They were certainly galvanised into very quick action. Here's our Prime Minister, the Right Honourable Jacinda Ardern, using a graphic, and I've sent a link in the chat to some of these graphics from the spin-off, which have been enormously helpful in communicating public simple concepts. And this is the flatten the curve graphic, which was widely used early on and predated, I think, the discussions about whether or not we could achieve elimination. So in the early phases, we didn't really consider elimination as a possibility, but later it became evident that it was feasible. Public health in New Zealand was in a parlous state, and many countries have observed this problem where decades of underinvestment meant that public health practitioners were not prominent, either in our medical schools in terms of training, but also the network of community-based public health professionals was fairly scanty here in New Zealand. And so the very simple premises that have served us well, there's no rocket science here. These are the things that you've all been talking about and were the suite of public health interventions that were identified in New Zealand. And these were captured in this very first version generated in early March of the risk levels and the alert levels with the actions that would be taken. These were based on the Singaporean model, which colleagues shared with us and put into this brand, which we have used extensively. These colours, these graphics have been used in a national campaign, which continues now, anticipating the rollout of vaccines. And so the New Zealand public got very familiar with these levels, level 1, 2, 3, and 4. In the early days, of course, we actually raced very quickly from level 1 through 2, 3, and a few days later into level 4, which is effectively as tough a lockdown, to use that term, as has been implemented anywhere in the world. And this is pretty hard to see. I'm happy to share this with the meeting organisers, but what you can see illustrated here is the sort of the sequence of government decisions that were made during February and then more urgent decisions in early May. And you can see here the imposition about this day here of alert level 4 led to an immediate control of the community transmission of cases. And we held on to this for a long time. As you can see, level 4 went on right until the end of March. And in a very precautionary set of decisions, we didn't release New Zealand to alert level 3 until early May, in effect. And that took a lot of political courage, as has been observed. So with acknowledgement to Michael Baker and his colleagues, we eventually cottoned on to the idea about an elimination strategy, and this was agreed by our government eventually in May, but the actions to empower this approach had been agreed verbally with ministerial colleagues much earlier than the final date of signing and publication, which was at the 8th of May. And the 4 pillars of this strategy are very obvious, have already been referred to during the meeting. Border controls at the heart of it, case detection. Contact tracing has been mentioned by a couple of you already, and contact tracing started very poorly in New Zealand with manual systems and paper-based, but we moved quickly to a national database using Salesforce, interestingly, a commercial platform, and then the development and deployment of an app, which has recently had Bluetooth capability added to it. And so that improvement in technology has sped up our contact tracing enormously. And then finally, the social license. Several people have touched on this already. This is at the heart of community support. And so just as we do in sport, we've heard about rugby, which is a pretty strong unifying sport here in New Zealand. The team of 5 million is something that the Prime Minister has used repeatedly to bind us together into collective action. Now, this is from Professor Baker's BMJ paper from late last year, and it was very helpful for us to have a bit of a mini tutorial, if you like, about what the choices facing governments might be, i.e. the language of this public health intervention, and the need to understand that elimination didn't really mean eradication, and the acceptance then of the pattern of disease that I've described allows for the stamping out of small outbreaks when they inevitably occur. And so that's been embraced and I think more widely understood as being at the heart of the elimination strategy for New Zealand. And just to touch on that, well, why? Because we can, we could, and those definitions became important to have a shared understanding of those. Obviously, unlike many landlocked countries, we are a long way from everywhere. And so the very courageous decision to virtually close our borders to everyone was surely an important, albeit costly decision. We've talked about population density. Obviously, we watched with alarm some of the rapid outbreaks in densely populated parts of Asia and other developing countries. But in reality, outside Auckland, our population is not densely is not dense, and so there are natural spaces in wider public facilities, and maintaining physical distancing was an easier prospect than in some places, particularly who operate mass transit, for example. I'll come back to the science-led response, but for those of you in that space, it has been heartwarming here in New Zealand in terms of the willingness of our senior politicians to follow science advice. And as always down under, we have very strong alignment with our Australian colleagues. So from day one, we have been aligning our science advice, our planning, our strategy, our public health interventions, and our approach to government with Australian colleagues. There have been differences. Those differences have been minor, and in general, Australia has achieved similar results to New Zealand, as has been mentioned. So just back to that public health response, this really doesn't bear repeating to this audience, but the last bullet point there is something that we've been trying to adjust our thinking, that the control measures don't include going back to level 4 every time there's a minor outbreak. And this has been something that has been a journey for us in terms of our own thinking about the public health interventions, and trying to get proportional responses and a more nuanced set of interventions. And so the government has asked us to do that, obviously, because it helps protect the economy. If we can have a proportional response and undertake rapid contact tracing and contain an outbreak, that will avoid more drastic national level action. So the mainstay for New Zealand has been keeping it out, and that has been a catchphrase for government and the wider public, Despite that, over 100,000 New Zealand citizens and some specialist workers and sports teams have crossed the border safely in managed isolation, 14 days in a strictly supervised hotel environment. The current outbreak appears to be, as I've mentioned, a leakage of cases who had tested negative at the end of their 12-day testing period prior to release, who have tested positive subsequently, and we're trying urgently using whole genome sequencing and other laboratory methods to try and understand what the South African variant, which is what we're dealing with here, may be behaving slightly differently in terms of its behavior in hosts. We have focused very much on the air border, and we've had to be very strict with our national airline and with incoming airlines to make sure that crew monitor and are monitored in appropriate levels of isolation during layovers. And we have a very long coastline, so it has been pretty challenging to manage entry across the marine border. So in terms of the science, obviously the whole genome sequencing has been a breakthrough for us and many other countries. We are able to do it within about 8 hours of a sample arriving at the laboratory with the rapid protocols, and we've been able to track and trace and compare whole genome sequencing with our epidemiological data for several months now. And this is a vital tool in understanding clusters. This is our last large outbreak, which started in a cool store in the city of Auckland, and the whole genome sequencing provided us with clear clues as to where the contacts and the transmission had occurred in other workplaces and the wider community. So in this privileged position, we are looking at vaccines not to manage the pandemic and the risk of ill health and deaths, but rather to continue to protect the border and our wider citizens. And we have been involved with COVAX and the other international consortia to obtain vaccines. And this is the current status in New Zealand in terms of the acquisition of vaccines. We have negotiated vaccine acquisition from these 4 companies and expect to have the first doses in New Zealand in 2 or 3 weeks' time, and they'll be deployed at the border in the first instance. So before I finish and take any questions that you may have, I've just tried to think about the success factors and the future for New Zealand. So we continue to aggressively pursue the elimination strategy, and notwithstanding the current outbreak, we have achieved that at least twice. Obviously, our border at a distance from everyone else, apart from Australia and the Pacific, is our key risk, and we'll be continuing managed isolation as a key protection for those arriving in New Zealand. We have had tentative safe travel zone discussions. We've just opened up one with the Cook Islands, which has been an easy decision. With respect to Australia, it's an on-again, off-again conversation. We have had some quarantine-free flights to Australia, but none so far to New Zealand. So the New Zealand government has taken a pretty hard line, and while states in Australia, such as Tasmania and Western Australia, have not had any cases, we've yet to open the border to travellers coming directly from those regions, but we will likely do so in the coming weeks. We are struggling right now to understand some of the testing profiles that we've observed. Cases testing positive after quarantine and negative tested is a new issue for us, which we're grappling with at the moment. And of course, as people recover and have vaccination, then their immune status will need to be more clearly understood as they arrive in New Zealand. So in hindsight, the critical factors have been the Prime Minister's own personal leadership. There was an awkward moment when effectively the then Minister of Health was stood down by the Prime Minister, and she took over the leadership of the response and became the Minister of Health in all but name. And she led this from the beginning. She had an insatiable appetite for detail. She had an extraordinary grasp of the information that she was being provided with. Various officials, including myself, are frequently summoned to her office to provide updates and debate opportunities for continuing the elimination strategy. And our academic colleagues, I should acknowledge them from around New Zealand and around the world, who have had a challenge function throughout. They have had wide media coverage, which has been balanced and sensible, and that has provided another voice, other than directly through officials such as myself, to the government to provide advice. Our Director General of Health, Dr. Ashley Bloomfield, has become something of a cult figure in the media. He has fan clubs and T-shirts and hats with his image on it. He has become highly trusted, and every day in the early phase of the pandemic response throughout March, April and May, he gave a daily address to the nation about what was happening, what we were doing. To go back to our Irish messages there, the colleagues pointed out that the how and the why need to be linked with the what. And that's been a lesson that we learned early on. And the Unified Communications campaign has been exactly that brand: unite against COVID-19, staying safe, washing your hands, staying within the guidelines of each level have been absolutely crucial to maintain the social license. So looking ahead for us, this working together as a team has been a national effort. Here in New Zealand, unlike sadly many colleagues overseas, we have a problem with complacency. We've had a reasonably free and easy summer holiday period. Our economy has recovered quickly, and there's elements of that where the domestic economy has been boosted by our sort of non-manufacturing economy, where we've still been able to export fruit and produce around the world in our airline, which has had no passengers but often carried hundreds of thousands tons of freight. And domestic travel and tourism has undergone a massive resurgence as people spend their holiday money out normally in Australia or the Pacific, have spent that money in New Zealand. So back to the public health system. In closing, our public health system will be rebuilt. This is the wake-up call. It will take some time, but I think we will be better prepared. And our science leadership group is advocating for the strongest possible investment in infectious diseases, research and surveillance capability. So thank you very much for the opportunity to talk with you today. I hope you found that helpful, and I'm happy to answer questions now or in the coming days by email. Thank you.
Very good. Thank you very much, Ian. It's really incredible to hear the story. And why don't we take a couple of questions? We do have about a few minutes. Who has, there was one question that I saw already. Are there people who in New Zealand who are actually unhappy with what was done and might be, saying, well, why don't we do what is done elsewhere in the world?
Yes, well, that's an excellent question, and it would be surprising, wouldn't it, if there were no doubters at all. So the team of 5 million has had its critics. There has been a sense that the top-down approach has not been particularly inclusive for some members of society. We have been at pains to engage with, support and champion the needs of Māori and Pacific Island people living in New Zealand, because their outcomes from infections are generally substantially poorer than for other members of society. And we have had a Plan B team. Plan B came very early and modelled itself on Sweden's response. There were calls for the lockdowns to be ended. These folk got quite a wide audience in the run-up to our general election, which occurred in November, and saw the current government overwhelmingly return to office. But a number of the opposition parties vying for votes had got involved with our Plan B colleagues, some of whom hold academic positions in New Zealand universities. And there have been some slightly testy exchanges, I'd have to say, between officials and some of our colleagues, just where academic freedom ends and being irresponsible starts, I think is a slightly fuzzy line. And I have taken to print media to rebut some of the claims made by those individuals.
Thank you. There's another question. Most Western governments seem to have largely dusted off their pandemic flu playbooks to manage COVID-19. But of course, COVID is not the flu. What was New Zealand's original plan? And I don't know, maybe Michael will be addressing this, but please say what was the original plan and what was the trigger for the change?
Thank you. That's a really good question too. So our influenza pandemic plan was the only document available. It would be fair to say that it was heavily coated in dust, probably had not been modelled or run in mock or real-time exercises for a decade. You'll recall that the WHO ranked us extremely poorly in terms of pandemic preparedness. And it'll be interesting to reflect on the comparison between the ranking and the outcome. I recall that the US, unfortunately, was probably higher than New Zealand. So the differences there are being discussed, obviously, at every level of wider society. Michael will comment on this, but was there a plan? Not really. Was there time for a plan? No. I think the agility of the science community and the willingness of the government to understand the different epidemiology of COVID-19, the way in which the exponential infections occurred and the need for urgent action just galvanized themselves in decisions that were made often late at night after hurriedly brought together advisory groups. Michael has been part of our technical advisory group from the get-go, and they've provided a crucial role in providing a sounding board and advice for me and my colleagues here at the ministry and providing guidance. So we now have a whole series of resurgence plans, which is the current language for New Zealand. Those resurgence plans obviously diverge enormously from what would have been a flu pandemic plan for obvious reasons.
So I have a question. At what point did you see that your plan diverged from much of the Western world? And what have been the opportunities or the thoughts that you've had about engaging with the broader conditions?
Yeah, well, I don't think we didn't really have time to reflect on that, to be honest. Yaneer, it was a white knuckle ride. It felt like we were in the eye of a hurricane. The normal machinery of government was collapsed into an all-of-government emergency response team. As I've said, the Prime Minister took individual control of the whole thing. Our line of sight probably was aided by the really collegial nature of what was happening in Australia and the willingness of their officials to talk to us on a daily basis. So that was helpful. And then, recognizing that we're part of an international science community, we remained incredibly grateful for the advice that we got from other countries. But we could see that where that advice was not being followed, as well as it was in New Zealand, that the outcomes were starting to be radically different.
Okay. So thank you very much. It's really incredible to have you here. I know your time is limited. Is there something else, maybe not as part of a formal presentation, but any other thoughts that you have that you would like to share with our group?
Well, just to acknowledge the suffering that's occurring internationally in other countries, and to, you know, repeat the offer that if there's anything that anyone would like to talk to us about in terms of strategy, be it communication, be it the machinery of government, be it the development of policy, we stand ready to support that and would do so very willingly at any time.
Thank you. That's incredibly helpful. Okay, and so now I would like to turn to Michael Baker, who is a well-known epidemiologist and a public health expert in New Zealand, and as far as I'm told, was the architect of this incredible response effort. Michael, would you like to take it away? I think you're muted, though.
Yes, thank you. Look, a huge thank you, Yaneer, for the introduction, and also for your leadership in at a global level with getting this meeting together. And I think it's the culmination of of a long-term effort on your part. So thank you. And also wanted to pay huge tribute to Ian Towne, because he has been, I know it wasn't in his job description to have to confront a pandemic, but he's done an outstanding job in, I think, being the person who we can all go to get science, a science overview of the response in New Zealand, and a critical leader in how New Zealand has responded throughout this whole period. And I was listening to the experience in Ireland, and obviously looking globally, and you know, we know we're talking with like-minded people here. We're just aware of the incredible frustration that we're all feeling with trying to translate science and good public health principles into action. And I think we were so fortunate in New Zealand that we had a courageous government that would listen. And I think that's and I'll come back to this in my presentation, the abiding lesson from all of this is the partnership between science and political leadership is just so critically important. So I'll just move on now to this presentation. And again, I think the host says it's disabled screen sharing. I'm assuming that's...
Are you not able to do that? Let me find out who is the current host. Either Matthew or Kim, or maybe do I have that authority now? Let me just see what I can
Katie
do.
is host.
Katie is host.
Okay.
I'm sorry, what are we trying to do? I think
Katie,
we're
apparently Katie is host, so she can allow Michael to share his screen.
Oh.
Here, just one moment.
Thanks.
Just having a little trouble.
The permissions today have been fussy.
And I'm going to it's still not, it's still disabling me from screen sharing, but
You're okay now.
You can do it now.
Oh, brilliant. Okay, thank you very much. Can you see that now?
Not yet. Are you able to share?
Yeah.
There we go.
Oh, great.
There we go.
Okay.
Perfect.
So I'm really going to build on Ian's excellent summary. And what are some of, I guess, focusing on some of the lessons that hopefully are generalizable from the New Zealand experience. So just again, some of this will be very familiar to the kind of strategic choices that we have for pandemic responses, that typology, what elimination consists of, and Ian's covered this, the impact, and some of the key questions and conclusions and lessons for the future. So we all know when you're assessing pandemics, the there's information that you have quite early on about transmissibility and severity, inequalities, and a whole lot of things you really want to know at the beginning that you don't always have. And I've kind of highlighted these in red. And some of these things we will only know in hindsight, probably the net economic impact, for example. So just again, reminding you that because to justify this huge effort, we obviously have to speculate early on about the various scenarios that may occur if there's uncontrolled transmission, for example. And so with my colleague Nick Wilson, who really led this work, we came up with, we think is what was probably still a very plausible estimate back in February last year of the likely impact of the pandemic in New Zealand based on certain assumptions. So it is about, it's not quite at the scale of the 1918 influenza pandemic, which is, I guess, a global benchmark, but it is certainly in that range, about 0.3% of the population dying. It's equivalent of 25 seasonal influenza seasons. I think we're all aware of the consequences. But one of the factors in New Zealand that was a very powerful motivation was a concern about inequalities. And this is showing a century of contact or experiences with influenza pandemics, and looking really at the rate ratio of mortality for Maori compared with European other. And even though that differential has dropped, even as recently as 2009, Maori was still significantly more likely to die in a pandemic situation. So equity was a big driver in New Zealand. So like many of you, I'm sure, when something of this scale occurs, you often remember when you first became aware of it and when you first absorbed the idea this was a really serious threat. And I know that sitting in New Zealand, and I think for many people, it was quite clear during January and certainly by the end of January, this was going to be a global pandemic. And obviously that was very depressing. But for me, the most important single event, I think, was seeing the report of the joint WHO-China mission, which confirmed that Wuhan really had contained this pandemic. And that convinced me that elimination then was possible and probably the preferred approach. The other realization was that by the time the virus was starting to transition from imported cases to local transmission, the realization New Zealand was not ready. We didn't have the infrastructure, and so that we needed an intense lockdown. One of the things that has surprised me throughout is that WHO in particular, although it was obviously very closely engaged with China and observed the experience of Wuhan in basically eliminating transmission, which was a phenomenal achievement, have really not pursued this focus on elimination since then. I mean, this is the very basic fork in the road, if you like, which applies to infectious disease control. And we obviously try and control most infectious diseases. And we've seen this split really between mitigation and suppression approaches in terms of our response across the globe. But elimination is a very well-established model, and many countries, most in fact, high-income countries at least, are pursuing or even achieving measles and rubella elimination. But eradication is obviously a much tougher goal and very rarely achieved, but is certainly in this typology. So as Ian's mentioned, this typology can be looked at a different way. And I guess the dotted line here is to say that exclusion elimination strategies have an exit path, which is obviously very attractive. And we saw early in the pandemic that this was achievable in countries like Taiwan and mainland China. So again, as Ian noted, and I think many of us are aware, across the globe, after 20 plus years of working on this, pretty much every country had a well-established pandemic influenza plan, which focused on mitigation and flattening the peak. And we in February, March, developed really the idea that elimination strategy was very appropriate for this pandemic threat. We assumed that this would be just a global movement in this direction because the evidence seemed so compelling to do this. I'm still quite surprised that we are, I think, one of the few countries that has a published elimination strategy. And the really remarkable thing was that our government committed to this strategy really on the 23rd of March, when it said it would pursue a rapid lockdown with only about 100 cases and no deaths. So that showed an amazing, I think, vision and commitment on their part. So again, just back to the basic, what's in the elimination strategy. In the end, we all are familiar with this, the pushing the reproduction number down and realizing that you've just got these very limited tools of reducing transmissibility, contact rates, and duration. And you've got, I think, almost a medieval tools until the arrival of vaccination, of course, for actually reducing the reproduction number. And so, again, looking at the components of elimination strategy, keeping it out, exclusion of cases is critical. Case and outbreak management, obviously focus on cases, testing, contact tracing, and so on. And then preventing community transmission. And at the moment, of course, we don't have vaccination in New Zealand. We had to use these basic methods of reducing transmission per contact or contacts. So again, these very simple measures. And another element, of course, is a social safety net, because we have to support groups who are really adversely affected by the elimination strategy itself. So looking at these components, there are so many remarkable things that happened that seemed almost inconceivable before this. And that this was the intense border management that you have to have with elimination, showing a 99% reduction in arrivals, and departures are very similar. And in fact, there were some days when no one came or left from New Zealand. And that had everyone looking through the record books to see when that had last occurred in New Zealand, and it was decades ago. So obviously, if you have testing, contact tracing, you need to build up this capacity very rapidly for high levels of testing. And there's some peak periods here of up to 25,000 tests a day during an outbreak in Auckland in August. So hygiene measures, the traditional approaches are obviously sensible, stay at home if sick, in particular, wash your hands and respiratory hygiene. But as we quickly learned, of course, these measures do not work very well on a respiratory infection where a lot of the source cases are asymptomatic and it's spread by respiratory droplets and aerosols in indoor environments. And this is really where mass masking came into play. For my efforts in promoting mass masking, I am now enshrined on one bit of packaging for one form of mask sold at the National Museum. So Ian's mentioned the alert level system, which I think was a brilliant piece of risk communication. I think the whole country now understands these levels. I think they can almost recite them. And behind the scenes, of course, there are many, many pages to explain what these levels mean for every activity in New Zealand. So one of the things that happened is New Zealand did a very intense lockdown. And you know, as I'm sure many of you have looked up the Oxford Stringency Index, which you can generate these graphs in just a few minutes. But one of the things that's interesting is New Zealand had 5 weeks at this intense lockdown, and then 2 weeks at level 3, a less intense lockdown. And since then, apart from when we had an outbreak, we maintained a low level of lockdowns, as opposed to many other countries. And it always seemed remarkable to me that there was a faction in New Zealand that said we should emulate Sweden, that we had this focus on lockdowns. Actually, this is one of the great benefits of pursuing elimination, is that you need to use lockdowns much less. So there are these amazing images. This is the rush hour in the main highway going into Wellington in the middle of this intense lockdown. So I won't say much about the safety net, but this was a huge focus of the government to protect vulnerable populations. And we're always concerned about unintended consequences, the direct effect of the intervention and the indirect effects from the recession. So there are all of these elements that need to be considered. So the impact of the elimination strategy, there's several publications now about this. This is one we published quite rapidly in the New England Journal of Medicine, just summarizing the phasing in of interventions and this decline from what would have been an exponential curve where we are transitioning from imported cases to local transmission. Basically, this was extinguished by effectively putting the whole country into home quarantine for 7 weeks. Again, you've seen some imagery of the genotyping, which has been an amazing tool. And this showed really that New Zealand imported the virus from all over the globe, a huge range of lineages. But interestingly, only about 1 in 5 of these cases transmitted the virus beyond one additional case. It shows how lumpy the transmission of this virus is. So I think there's some key questions here, and I'm just aware of time, but these are some of the questions that have come up about the elimination strategy, and I'll just run through these quickly, because I think some of them are relevant to, I think, the wider discussion about generalizability of this strategy to other places. So quite clearly, eliminating COVID-19 is a very good way of reducing mortality. New Zealand's has the lowest COVID-19 mortality in the OECD. It's not, and it's by a huge margin, of course. It's by about 100-fold less than the OECD average. And of course, these numbers are continuing to go up. Does it protect the economy? Yes, and we have included this initial analysis in this B&J paper, but basically, and it's a very busy slide, this does show how that not only do you have much less lower mortality in countries pursuing elimination, but also there's less economic contraction. And in fact, China has net economic growth based on GDP in 2020, and these are IMF estimates. And Taiwan is probably going to be maybe slightly in the positives. And the New Zealand estimate is actually going to be less than this when it's revised. So you're not sacrificing your economy. It's people and the economy go together. And I think, I'm sure all of us are saying the same message, but I think the evidence is there now. So an element of sustainability, it is sustainable. This was always a fear in New Zealand that we would get border breaches. And we've had a number of these. These are these red marks here where you get local transmission, but that these would be hard to contain. And in fact, I think because our contact tracing has been built up during this period, it had the capacity to manage these events. And I think it's a huge tribute to the public health sector in New Zealand. So resurgence planning, this is, as I'm saying, involves a lot of contact tracing. We have the ability to raise the alert levels, and that was done in the Auckland August cluster. And we have not really relied on mass masking particularly, but it's now at least an option that's being promoted more actively. So is it generalizable to diverse jurisdictions? Well, there are a number of countries that are pursuing this to a high degree. It's sometimes hard at a distance to know exactly what's happening in some countries and the quality of their surveillance. But looking at the reported data, these seem to be countries that are clearly achieving it, or at least aspiring to it, and having low, apparently low incidence of COVID-19 and mortality. So this is a really a case study about its generalizability. I think there's the Wuhan experience, but that may not be so generalizable to liberal democracies. But here we can see in Victoria, Australia, they actually had a very intense resurgence where they had rates that were markedly higher than the UK for many weeks. And they actually used a very targeted lockdown to basically stamp out this infection and achieved return to elimination. Actually, they had never totally achieved it, but they did achieve elimination and are sustaining that. So I think this is probably one of the best case studies of the fact that it is generalizable, this approach. It is also generalizable to other potential pandemic diseases. And I think this has been demonstrated in New Zealand and a number of other countries pursuing elimination. This was our influenza epidemic curve over last winter compared with previous years. So that is good news that this method can also be used on pandemic influenza, which has a lower reproduction number than COVID-19. So I think that's a great lesson for the future. And one other thing in New Zealand, we eliminated our excess winter mortality, and all-cause mortality has actually declined by 5% in New Zealand. So basically, at the end of last year, we'd estimate that we had saved 5,000 lives if we had compared with what would have happened if we'd had the OECD average mortality. We also saved perhaps 2,000 lives through people who didn't die through excess winter mortality, which is driven by respiratory infections. So that's around 7,000 lives, which for our population is quite a significant number. Can it be done better? We've published a detailed comparison of New Zealand and Taiwan, and I think Taiwan really has achieved remarkable success based on a whole lot of indicators of very low, very good control of local transmission, and very little or no lockdown needed and sustained elimination. So we've really distilled what we think are the key lessons there for ourselves, and hopefully other countries can look at this. So the other thing we think is a long-term lesson is moving away from pandemic plans that are based on a single pathogen and to an all hazards approach. And this is our thinking around what that might look like, and this will be freely available online shortly. So the big conclusions we have from this, and these are largely covered in this BMJ paper, that we think the evidence is very, very compelling that elimination is preferable to mitigation and suppression. We think it can be achieved and sustained in very diverse jurisdictions. And we'd say that probably it's the preferred response to any new emerging infectious disease where it has pandemic potential and where it has moderate to high severity, where while you're waiting to estimate key parameters. So I guess this is the precautionary principle, and hopefully the World Health Organization will, I mean, I think there's a lot of things they have to absorb from this event. And again, our conclusions are that elimination is favored by certain conditions, and this is really a subjective assessment, but it's partly based on our own experience, that these are really critical preconditions for elimination to be adopted and to be successful. And once again, I think just to reiterate, effective science and good political leadership. It seems to be no accident that many of the countries that have done well or performed well with this pandemic have female heads of state. We know association is not causality, but I'm quite convinced. And again, I think the silver lining has to be that this is the great case study and the lesson globally about the need for a broad reset to focus on these global health threats. Certainly in New Zealand, green recovery has huge support. I think it's probably a global movement, and equity is also at the core, I think, of an effective response. And I think that would be one of the other elements that's been emphasized time and time again in New Zealand. So to summarize, science and leadership, I think the evidence is in. Elimination achieves better results by every indicator. It's an opportunity to strengthen public health and also this major reset. And again, huge thank you to my many colleagues, and again, wonderful, at times, interesting relationship with our health agencies and our politicians, but it actually has been really wonderful experience working across all of these groups. And just a reminder that New Zealand is a bit of a village. It does give us an advantage. We can pick up the phone and talk to people, and that's been hugely helpful. Thank you.
Thank you, Michael. One is amazingly impressed by how reasonable the actions in New Zealand have been. And of course, that would have been a very good story to tell as something that had been adopted more widely. I can tell you that a year ago, I was hoping that the same kind of actions would be adopted everywhere. Obviously, they have not, and we still have a tremendous amount of effort to do in order to get there. Shall we take some questions? Please, we have a couple of minutes for questions. So I guess this is the question. Any suggestions for countries who have high cases now? Can strict lockdown now get us to COVID zero, or zero COVID?
Suggestions for progressing.
Yeah, suggestions for countries that are now in dire status. What would you recommend?
Well, I think the essence of elimination approach is this idea of a single-minded proposition that actually, and I think it's been articulated, I think, by several of the speakers from Ireland and others, that having that focus works. That one of the huge weaknesses of a suppression approach is that no one knows what that actually means in reality. I mean, how many cases can you live with? And it's extremely hard, it seems, to coexist with this virus. Whereas I think committing to zero COVID with, and obviously vaccines are going to help. We don't know if they interrupt transmission, but they're very likely to have an impact on that. We're extremely well placed. I mean, any high income country can do this, but I think it's having that single-minded proposition accepted. If you don't have that accepted, I think there are problems.
And I'm going to ask a leading question. What can we do globally to help bring the information from New Zealand, Australia, Taiwan, Vietnam, and so on to the countries that have, for multiple reasons, and continue to pursue the ineffective suppression mitigation strategies?
Well, you'd think this would be a role for the World Health Organization. And I don't know how many of you work closely with WHO, like I do occasional work for them, but at the core, they have not led this paradigm shift. And I find it very frustrating.
Yeah.
So I'm sure collectively there are people in this call who are on this meeting who can raise this with them. I do find it remarkable that this is a strategy that's protecting a sizable portion of the world's population, and yet elimination does not feature in any of their communication that I'm aware of. So they have the mandate to do this. So that, I think, would be a really critical advance in thinking.
Thank you. Is there any other questions? There are a couple of comments here about having a global health summit. And indeed, this summit is not domestic. It is intended to be global, as is evidenced by the participants and the speakers. But surely there is opportunity to do more and more of this communication. There's another question about the difference between physical distancing and social distancing. Would you care to answer how you think about those two terms?
Yes, I mean, this is an attempt to re-engineer language, and quite deliberately, because we want people to be socially connected, but physically distanced. And the term social distancing always seemed, it has some negative connotations. So it may be a losing battle because social distancing is so entrenched in the literature. They are synonyms, but it's intended to convey a different flavor. And I think it's partly the view that language matters. I don't know if we'll succeed. It's just like quarantine and isolation. Those terms are used very differently, almost interchangeably, even though they've got decades, I don't know, even a century or more of very specific usage. So as an epidemiologist, I get very frustrated that they are used. New Zealand, for some reason, is using them in almost reverse order. So reverse meaning, I don't know why, it's a bit of an accident. Yes.
So we have extra time. We have about 20 minutes for additional questions or conversation. And from our previous session, I see Tomas is still on, and I don't know if he would like to turn on his screen, and maybe you have questions for each other that you would like to pose. I think I'm sure that people would enjoy that opportunity for hearing your dialogue. And others who would like to ask questions and participate in the conversation, I think this is a good opportunity to have that take place. While you are thinking about it, let me ask some question. You mentioned the interactions between New Zealand and Australia, and at the same time, and that was also mentioned by Ian Towne, I think. Please elaborate just a little bit more about those interactions, and tell me which other countries, whether geographically proximate or not, have been, if you will, the most interactions. Have you, in fact, had interactions with either China or Taiwan or Vietnam or so on?
Yeah, well, certainly New Zealand and Australia have a huge amount of interaction with very similar cultural heritage and geographically close together. There's a huge number of New Zealanders living in Australia. And I think right throughout the whole pandemic, health officials in the ministry have talked at least daily, probably many times a day at different levels with Australia. So it does make sense that we shared approaches. But at one point, New Zealand departed from Australia, and that was on the 23rd of March, when we said, actually, we're going to go into this intense lockdown to eliminate the virus. In fact, the politicians were not comfortable using the elimination word because it seemed the bar was too high. They did talk about stamping out the virus and keeping it out. So again, language is sometimes quite important. And Australia didn't do that. It has a more conservative government at a federal level, and they preferred what they called aggressive suppression was the term they used. But some of the states were totally committed to elimination, and they pursued that. And some of them closed their borders to one another, a bit more like what you might see in a federal system overseas, like perhaps Canada or I don't know about the United States as an example, but in a federal system where, and I think Germany is actually an example where the main responsibilities are not at the federal level for health and health policy. So Australia, parts of Australia have kept the rigid border restrictions with the rest of Australia, and they're now opening up as Australian states are eliminating the virus. But I think by not committing to elimination, I think that created real problems for Australia. And I think that was an underlying cause of the big resurgence they had in Victoria, because they were tolerating low-level transmission until it became a large outbreak that couldn't be controlled easily. So the other interactions we have is with Pacific Islands, and I think particularly South Pacific Islands and Polynesia, and there's a large number of Polynesian people who've migrated from those islands to New Zealand, so we have very strong links. And we're now in the process of opening up travel corridors with, so far, just one of those island countries, but we hope to do more. And the other country, and this is just myself, I've talked a lot or worked a lot with the epidemiologists in Taiwan, because we were really interested in their great success and wanted to learn from that.
Very good. Who else has a question for Michael? So there's a question. Do you think the public's knowledge and understanding of their government's pandemic plan could help sway pressure for governments to adopt a better plan?
Yeah, it is always interesting how what aspects of the response require huge public support and which are more technical, because in many cases, some of the key responses are very much what we call more the health protection than health promotion. Managing borders, for instance, and implementing very intense lockdowns. These are quite tough measures that often governments have to decide on balance of evidence and needed. And then you obviously have to communicate that to the public. But it may be very hard to get public consensus around these measures. So I think it is a negotiation process and trying to engage the public. But particularly at borders, I think, which is a critical point, that is, I think, quite a major decision by governments they have to make. And they've got, I think, the mandate to do that. I don't know that the public are always on board about that before it's done.
So I have a question which may not be entirely comfortable. Your statement about the WHO, I think, is something that I can at least say myself, and many people here have been quite critical of WHO. My criticism of similar issues extends back multiple years to the Ebola outbreaks. But in this context, there's been a professional failure in relation to your quite reasonable statements. When you put up your presentation and you say elimination is a choice, and it's a well-established epidemiological choice, that's not the message that is being heard in multiple places in the world from the epidemiologists and public health experts. Where did that get lost? How did that happen?
I guess that will be one of the great questions that's analysed for many years to come, because I'm actually, just in the elimination case, for example, I'm on the WHO Regional Verification Commission for measles and rubella elimination. And so we meet across different parts of Asia every year to review progress. So this is a WHO-sponsored process. So they have plans for eliminating a number of diseases. So it's absolutely a core concept that they promote. So somehow this concept, this paradigm was not applied to this virus. And I think a lot of it is about the huge momentum that pandemic influenza planning has had. It's dominated the thinking, and modelers in many countries appear to have also perpetuated that. And I've talked to colleagues, and particularly, we normally look to leadership because New Zealand's got a very small science capacity. So when we see a pandemic, we immediately look to the World Health Organization, the US CDC, Public Health England, European Centers for Disease Control. We're looking at all of the documents they're producing, and they did not emphasize the threat very early, and they certainly did not talk about elimination strategies. So I think the last possible moment, we are looking at Asia and saying, those models are working there, that's what we should do.
So there's another question. To what extent were big business, vested interests, political donors, etc., pressuring New Zealand government to stay open, or were they largely on board early?
Well, this is one of the remarkable aspects of the New Zealand story. The other group that was lobbying our politicians were our business leaders, not what I'd say is small business. These were the international, very wealthy business elite who said, basically, and I think it was a bit of a Lifeboat New Zealand framing, They could see what was happening globally, and they said, look, you've got to take this seriously, take extreme measures to protect the New Zealand society and also New Zealand economy. So they could see this, and also I think were quite visionary. And I think it's the only time in my life when I was jointly talking with the Prime Minister and Finance Minister with the business leaders saying the same thing. It was remarkable. I'm not sure if that will ever happen again.
There's another question about back to the WHO. Why do you think they have been slow to acknowledge and address the evidence of the central fact that COVID is airborne?
Yeah, I think that they have done the same with mass masking. They were very late to say this was a useful strategy. I don't know. I mean, there's, I think Helen Clark, for instance, as you know, is jointly leading a review group. They've put out their second preliminary report, and they're going to report finally in a few months' time. And it was very critical of the World Health Organization and China for the slowness of their responses at key moments when this pandemic was manageable with decisive action. And I don't think they're going to be, I think they're going to be very direct, which is good. So it may identify that there's some core issues. And I think one of them we have to say, of course, is that the World Health Organization has been hugely underfunded and under-resourced to do its job. And I think that's pretty evident during the response. And I think that extends to their ability to assess and look at evidence. The other thing is they're a membership-based organization, so their normal decision-making processes try to get a lot of engagement and consensus from member organizations and member states. And I think that can be very slow in an emergency response.
Yes, I think I would affirm that the fact that they're members of the countries creates a somewhat maybe a conflict in terms of their ability to provide guidance, maybe. I don't know. But let's talk about one other detail, which seems not so important, but when the WHO report came out about China, they used the term non-pharmaceutical interventions. That's not the terms you use. Would you care to talk about that?
Excuse me.
Okay.
I think the term non-pharmaceutical interventions is a standard term used for, it covers all the things that you do in the early stages when you don't have vaccines or antivirals. We do use that term as well. Some people say it's better to talk about public health measures, but no, I think that's just different terminologies for the same thing. So okay. Managing orders, quarantine, isolation, contact tracing, and so on.
The reason why I question it is that it seems to say that the center is the pharmaceutical interventions, which I might wonder why that would be the order of priority under the circumstance. That's something that I have wondered about. Okay. Is there anybody else who has a particular question? We're coming toward the end. And I think we've had good questions. I think the others are more comments than questions. So maybe we'll turn it back to you, Michael. Do you have anything else you feel that we should hear about? You gave a presentation, which was a prepared presentation, but maybe you have some additional thoughts to share.
Well, for me, the fundamental driver of change is to identify that zero COVID is a far better goal than the alternatives. we sometimes say the least bad choice, because whatever you put forward involves huge more than inconvenience, actually suffering for some people. One of the things is I always think is the prevention paradox. I don't know if paradox is exactly the right term, but this is the idea that when you, in public health, if you intervene effectively, nothing happens. No one dies, and there's less disruption to economies. And so people after a while feel, well, we don't need to invest in that anymore, because the people who are saved from dying or don't suffer long-term consequences are invisible. And so they're not an advocacy group for action. But if you talk about all the things you have to do with elimination, that hurts people directly. It hurts their livelihoods, their businesses. And some people will probably die or be injured as a result of some of these measures, because they are involved massive disruption, telling the whole population go home for 7 weeks. That has definitely hurt people. But on balance, the benefits are much greater, but you have to use modeling and you have to use persuasion to identify those benefits. And meanwhile, you've got the clamor of people saying, no, don't shut the borders, you're wrecking our livelihood and everything. So I think this is the prevention paradox writ large in terms of the barriers to actually doing the right thing. And that, again, is one of the lessons that I take from this episode. In New Zealand, we had to, I think we had a compassionate government who was also smart, and they could see that there were net benefits in pursuing this approach. So I think now, of course, almost a year on, the evidence is so compelling that we don't have to use modeling anymore. We can use case studies. We only have to look at China. I mean, they are emerging from this in very good shape, both from relatively low health impact, certainly amongst the lowest COVID-19 mortality rates in the world, and with the economy thriving and many people returning to the new normal very effectively. And may be able to sustain this with a very long, complex land border, a huge population, densely populated cities. So I think the evidence is there now. We don't have to just produce a hypothesis that this will be beneficial. It's there, and I think we all need to act on that. So thanks for the opportunity to talk with you all.
Thank you. And once again, it's so amazing to hear both from Ian and your presentation that a system can work, that there can be government leaders that take it seriously, that there are scientists that are available to inform them, that have the right framework of information, and that the collaboration can result in safety and well-being for the population. And now we have to figure out how to translate that to other places in the world. And the example that you've given us is super important, because as you said, we have the case studies. And while you just pointed to China, surely the case study in New Zealand has been an incredible thing to aspire to as we engage in this challenge globally. Thank you very much. I think we all appreciate, again, a round of applause would be very appropriate, and we will do so in our limited virtual way. Thank you so much, Michael, for joining us in this program.
Thanks, Yaneer.